Good morning, students. This is Professor Eknath Ahire from Divine College of Pharmacy, Satana, Department of Pharmaceutics. Today, we are going to discuss about pharmaceutical distribution. So, basically, in previous session, we discussed about absorption. If you people are not aware about absorption, so go to the previous video and see that absorption, because without absorption you are not better understand about distribution process, because we are studying about pharmacokinetic. So pharmacokinetic process contains four type of different processes, which is called as ADME: A for absorption, D for distribution, M for metabolism, and E for elimination. So we are going to see one by one. So in previous session we already discussed regarding absorption process. In this session we are going to discuss regarding distribution process. Okay, so let's start. uh, uh, the definition of the distribution is: it is the process where by an absorbed chemical moves away from the side of absorption to the other areas of the body. Following absorption, which may be from skin, lung, or GIT, or systemic administration, which includes IV, intravenous, intraperitoneal, or the intramuscular route into the bloodstream. A drug distributes into the interstitial and intracellular fluids. Okay, so interstitial means in between the cells, and intracellular means within the cell. Okay, so interstitial fluid represents about 15% of the total body weight. Okay, then intracellular fluids, which is found inside of the cells, which contains or which occupies 40% of the total body weight. Then blood plasma occupies the nearby 8% of the body weight. So the rate of the delivery and the potential amount of the drug uh, distributed into the tissue depends upon cardiac output, regional blood flow, capillary, and permeability over the tissue volume. Okay. Then well perfused organs, for example liver, kidney, and brain, initially receives most of the amount of drug, and as compared to this, the muscle, most of the viscera, skin, and fat liver are the slower extent of the drug received. Okay, so distribution is basically what: after the absorption, the drug is distributed or the transported over the body, or the different organs into the body. Okay, so that process is called as a distribution process. uh, Basically, or the primarily, your drug is absorbed in the body. It is now in your systemic circulation, but after the systemic circulation, the distribution process is started over there. The drug is distributed within the body, or the in the body, to the different parts of the organs. Okay, or the different organs. Okay, so we have or we have to know about this distribution process for the better formulation development. Okay, if you don't have if you don't know about the target, then you don't have to uh, uh, you don't get much more idea for the formulation development, or where we should it should target into the body. So uh, for this purpose we have to know about the distribution process well known, or the very well. So it determines the transport of the drugs to their site of action, to other sites, and to the organs of metabolism and excretion. And it is always not uniform in the body. Also, difference in the perfusion rate. Okay, in case of distribution process, there is uniformity is there, because we can't predict over there the distribution of the drug over the all body organs are similar. It may be differs depending upon the different factors, and it easily penetrates to the capillary endothelium, diffuses across the cell membrane. Okay, so these are the leakages, we can say leakages over there, or the different parts having the different type of distribution over there. The distribution is the dispersion of the drug among the various organs or the compartment within the body. Okay, so it is the distribution process within the body or the within the different compartment in the body. The apparent volume of the distribution, which is termed as VD, has been has been divided or the device to describe the distribution of the drug. So distribution of the drug is mostly calculated by using the volume of distribution, which is termed as VD. Apparent volume of the distribution is the theoretical volume that would have to be available for a drug to disperse in if the concentration wherever or the everywhere in the body were the same as that in the plasma or serum, the place where drug concentration sampling generally occurs. Okay, then VD is the volume which which is in the liter per kg into which the drug appears to distribute, and it is calculated from the dosage, which may be always in the gram or kg, and the concentration of the drug in the blood, which is in kg per liter, and body weight in kg. So the formula for the calculation of volume of distribution is equal to D for drug upon Cp plasma concentration into K for constant. Uh, Suppose one example is there. Assume that 100 gram of alcohol are ingested by a man who having the body weight of 70 kg, and the blood level is found to equal to 2.38 gram per liter, which is the presence of alcohol into the human body per gram per liter. Okay, so we have to put these values into the above formula, which is Vd is equal to D upon Cp into K. Okay, so after putting of this value, we will get Vd is equal to 0.60 per liter per kg, or the 42 liter for this man. So according to this, we can calculate the volume of distribution into the body of given drug. Okay, so volume of distribution values range from about 5% of the body volume to as high as 400 liter. We can calculate over the range of the volume of distribution. The latter figure is much higher than anyone's total volume, so VD is an artificial concept. So it is a theoretical concept, it is not a much more practically, it is a theoretical only. Then what is important of this, it will predict whether the drug will reside in the blood or in the tissue or not. Okay, so we can predict from here how much amount of drug is reside is into the tissue or into the blood. So we can calculate from this. So water soluble drugs will reside into the blood, and fat soluble drugs will reside into the membranes or into the adipose tissue and other fat rich areas. So we know that the uh, fat soluble drugs are always found into the different types of tissues, and the water soluble drugs are found into the blood. Then the volume of distribution also relates to whether a drug is free or it may be protein bound. Okay, drug that are charged tends to bind to the serum protein, and which drug having the better charge, which are always binds to the serum proteins. Then protein bound drugs from the macromolecular complexes that cannot cross biological membranes and remains confined to the bloodstream. The pathophysiological states may also changes VD. Okay, if it is any disease condition is over there, then maybe of that disease condition or the pathological condition, the VD or the volume of distribution may affect or may changes. It may be increases or it may be decreases because of VD, because VD is a mathematically relates to blood concentration to dosage. It may be employed in the interpretation of laboratory result. It may be theoretically interprets the laboratory results. It is useful for providing an estimate of dosage. It follows it follows that it can help estimate the amount of antidote to be given. So it is more or the most important in case of the poisoning. We can easily calculate the uh, dose of the drug over the antidote over the that poison, means we can easily predict or easily decide that the dose of antidote. Okay, then it indicates whether there is any value in trying to enhance elimination, as for example by dialysis, or it is also useful for the dialysis process also. Then VD is also helpful in the context of drug monitoring. It is also important in case of the drug monitoring process. It predicts whether the practice of drug measurement in blood will have any clinical value or not. Then different psychotropic drugs such as tranquilizers, antidepressant, antipsychotics, mood altering agents, etc. creates their effect by binding at site within the central nervous system. So we can predict this psychotropic drugs concentration also by using of this volume of distribution. Then this is the uh, table regarding the volume of distribution of the selected drug or the or the different type of studies. So you can see over here the plasma level correlates with the effect or plasma levels unrelated to the effect. So some drugs are showing the effects and some drugs are not showing the effects. Okay, so you can see over here acetaminophen, aminoglycosides, digoxin, ethanol, ethylene glycol, ibuprofen, methotrexate, salicylates, and it having the averages of the 0.58, and in another case we can see the average of 7.05. So in both cases we can say that the plasma level in uh, concentration in some uh, in case of some drugs it affects, and in some cases is it is not or the unrelated to the effects. So volume of distribution is an abstracted concept. It gives information on how the drug is distributed into the body, and it is theoretically only, not a practical concept. And it is used to calculate a loading dose also. Okay, and this is another chart where you can see the general relationship among the volume of distribution at a steady state, which is called as a VSS, the extent of protein binding and the distribution characteristic of drug. You can see here if the volume of distribution at steady state more than 1%. So, and if drug is basic, then more binding in the tissue than in plasma. And distribution characteristic in the body, a drug may be concentrated in the particular tissue in the body. So we can predict if volume of distribution at steady state is more than one, then we can predict a drug may be concentrated in the particular tissue in the body. It is deposited in particular tissue only in the body. We can predict from this. If it is 0.4 to 1, so we can say the general trend into the protein binding, similar binding between the plasma and tissue. It may be binds to the plasma and tissue, and drug distributes uniformly throughout the body. If we have to predict, if it, the volume of distribution at steady state having 0.4 to 1, then it is great uh, greater to predict that the drug is uniformly distributed throughout the body. So we have ideally keep it as 0.4 to 1%. If it is less than 0.4, then uh, maybe drug is acidic, then more binding in the plasma than in tissue. Then distribution characteristic is drug molecules are confined mainly in the plasma pool with limited distribution to the tissues. If this condition is there, then drug molecules are found in the plasma pool. Next part is clearance. The ability of organ of elimination or to clear drug from the bloodstream is known as clearance, and it is abbreviated as CL, and mostly clearance or the clearing organs are kidney and liver. Volume of fluid which is completely cleared of drug per unit time. Unit are in liter per hour or the liter per hour per kg. It may be there. Or then pharmacokinetic terms used in determination of the maintenance dosage. The volume of distribution is a theoretical volume and determines the loading dose. We already discussed or previously discussed. Clearance is a constant and determines the maintenance dose. The rate of elimination is equal to KEL into D, where is the remembrance that C is equal to D upon VD, drug upon or drug by VD, or the volume of distribution, where KEL is the elimination rate constant. Okay, and therefore D is equal to C, or the concentration into the volume of distribution. Rate of elimination is equal to elimination rate constant into concentration into volume of distribution. The rate of elimination for whole body is equal to clearance or the total clearance into the concentration. Combining the two, or with by combining of this above both equation, will get the total clearance is equal to elimination rate constant into the volume of distribution, where CL and VD are the interdependent variables and K is the dependent variable because K is constant. Uh, Volume of blood in a defined region of the body that is cleared of a drug in a unit time. Okay, then clearance is a more useful concept in reality than T half or the rate of elimination constant, since it takes into account blood flow rate, and it matters upon the blood flow rate. If blood flow rate is more over there, then elimination or the clearance rate also more over there. And clearance varies with body weight, and clearance is always varies with the body weight, also varies with the degree of protein binding. Okay, it is also varies with the degree of protein binding, because more protein binding is there, then more time required for the clearance or the rate of clearance. Then some factors are there which affects on the distribution of the tissue permeability of a drug. First factor is the physicochemical property of the drug. Second factor is binding to plasma and tissue proteins. Next is blood flow. Then facial compartments and barriers, and disease states, which is also known as the uh, disease state or the okay. So disease state only. So we'll start with first factor, which is physicochemical property of the drug. Drug molecular weight, which having less than 500 to the 600 Dalton, are easily cross the capillary membrane to penetrate into the extracellular fluids, except in CNS. Okay, because junction between the capillary endothelial cells are not tight as much. So it is passage of the drug from the extracellular fluid into the cells. Molecular size is also important. Degree of ionization also impact over the lipophilicity. So depending upon that parameters, or these parameters may affect on the volume of distribution over there. Okay, so physicochemical properties also important over there. So we have always we having always requirement of less than 500 to the 600 Dalton uh, of drugs having molecular weight over there. If it is there, then it is easily crosses the capillary membrane and easily distributed or throughout the body. The water soluble molecules and ions of size below 15 Daltons enter the cell through the aqueous fill channels, whereas those of larger size are restricted unless a specialized transport system exists for them. Okay, then according to the pH partition hypothesis, basic drug present in blood which having pH 7.4 readily enters into the acidic tissue and fluids, including the intracellular fluids which having pH range of 7.0 and concentrate there. Then conversely, acidic drug attains high concentration in the relatively more alkaline body fluids. So it having requirement of the opposite type of pH ranges. Okay. Example: weak acid bases administered parenterally diffuse passively from the blood pH having 7.4 into the rumen fluid, which is mostly found in the animals. Okay, you already know that animal having two types of the stomach, or two type of the stomach over there. One is having the digestive system and one is having the for the purpose of the storage only. Okay, of the castle and the sieve, where they become trapped by the ionization. Similarly, weak bases tends to the accumulate in milk since the pH of the milk is slightly acidic, which having the pH range 6.5 to 6.8 to the blood. Then transportation of the drug are transported in the circulating blood in two forms. One is in a free form and another is a bound form, which is a plasma protein form. Free form of the drug is usually dissolved in the plasma and is pharmacologically active, diffusible, and available for metabolism and excretion. So next is binding to the plasma protein. So significance of the plasma protein bindings are of it affects the distribution. So one disadvantage is there, it affects the overall distribution process, but it is pharmacologically inactive, non-diffusible, not available for the metabolism or the excretion, as they cannot pass through the capillaries and cell membranes because of their larger size, because it's having in the complex form with the protein, drug having in a complex form with the protein. Because of protein's higher molecular weight, it is not easily passes through the capillaries. The plasma protein binding of the drugs is usually reversible because it is a weak chemical bonding. Then covalent bonding of reactive drugs such as alkylating agents occurs occasionally. It happens occasionally. The binding of the individual drugs ranges from very little, for example, uh, theophylline 2, to very high, for example, warfarin. In circulating blood, there is a constant ratio between the bound and free fraction of the drug. When the concentration of the drug, free drug falls due to the redistribution metabolism or the excretion, the free bound ratio is maintained by dissociation of the bound from the drug. The plasma protein binding mainly serves as a reservoir. So we can say that the plasma protein binding is always serves over there as a reservoir, because whenever we have to require, we will get the drug from that plasma protein, which supplies the free drug whenever required. You can see the free drug, it ready for the requirement. uh, you can see over here the reversible drug binding to albumin is critical to effective drug distribution. It may be present in the plasma or it may be present in the tissue. Always free drug is available over there. The free drug concentration gradient drives transport across the membrane. The large variety of the drug ranging from weak acids, neutral compounds, and weak bases binds to the plasma proteins. The acidic drugs generally binds to the plasma albulin, and basic drugs to alpha acidic glycoproteins binding to other plasma proteins. For example, lipoproteins and globulins occurs to a much smaller extent over there. Then different drugs binding to the different proteins. If binding site is acidic or acidic agent is there, then it binds to the albumin or albumin protein. For example, bilirubin, bile acids, fatty acids, vitamin C, salicylate, sulfonamides, barbiturate, uh, probenecid, uh, phenylbutazone, penicillins, tetracyclines, etc. Then binding site for the basic drugs, it is globulins. So, for example, adenosine, uh, quinacrine, quinine, streptomycin, chloramphenicol, digoxin, uh, quabin, wabin, and coumarin. You can see over here the plasma proteins in human. One table is there which showing the different plasma proteins, like albumin, alpha 1 acid glycoprotein, lipoprotein, globulin, steroid, um, steroid binding globulin, which is also called uh, transcordin, and fibrinogen. And you can see over there the molecular weight of each, and it having the plasma concentration in the body, and the ability to uh, binding over it. It may be acidic or basic or the steroid drug are there. You can study thoroughly. uh, for the majority of drug binding to plasma albulin, which having the weight or molecular weight 65 thousand, which comprises more than 50% of the total proteins, is quantitatively more important. The binding of the drugs to albumin may show low capacity, one drug molecule per albumin molecule, or high capacity. It may be two or more drug molecules as per albumin molecule. The albumin, uh, albumin can bind several compounds having varied structures, some substances even to a single site. Group of drugs that binds to the same site competes with each other or the binding. Some drugs may bind to the blood component other than plasma proteins. For example, phenytoin and phenobarbital binds to the hemoglobin. Here is the uh, one table is there which showing the various physiological or the pathophysiological condition altering the protein concentration. You can see over there the changes may be increases or the decreases, and you can see the pathophysiological condition over there. Different type of disease condition is there, and over that condition different type of or the three type of proteins are there. One is albumin, one is alpha acyl glycoprotein, and one is the lipoprotein. So what type of effect over there onto this type of this protein or the different type of disease condition or the uh, pathophysiological condition or the physiological condition, so you can study in detail. So enough for the day. Remaining